The purpose of this video is to demonstrate how the Endopore dental implant can be used with the indirect or closed osteotome-mediated sinus elevation approach to restore the resorbed posterior maxilla in a minimally invasive and highly predictable manner. The procedure can be done in as little as 3 millimeters of remaining subantral bone height for the patient with an enlarged sinus cavity, thereby avoiding the significant expense and risk associated with the alternative direct lateral window open sinus elevation procedure. The unique implant surface geometry of the Endopore implant offers the advantage of osseointegration by bone ingrowth, rather than the more usual linear bone contact at the bone-to-implant interface offered by threaded dental implant designs. This bone ingrowth results in a rigid, three-dimensional mechanical interlocking of bone with implant surface, and a very secure implant fixation to bone. Research over more than 2 decades has verified that this type of bone-to-implant fixation makes the Endopore implant ideal for use in lengths of 7 millimeters or less and in the cancellous bone typical of the posterior maxilla. The main limitation for the treatment to be demonstrated is that the operative site must have adequate alveolar ridge width, the minimum being 5 millimeters and the preferred width being 6 millimeters or more. As well, the procedure is not indicated in patients who smoke or in patients with a history of chronic sinusitis that might affect the treatment outcome. The patient to be treated in this demonstration is a 41-year-old male with multiple missing teeth, including the maxillary right second premolar and first and second molar teeth. The plan was to replace the second premolar and first molar teeth with 2 7-millimeter long Endopore implants and 2 separate non-splinted crowns. In the opposing arch, the patient was missing the molar teeth, and of these, the first molar was to be replaced with a single Endopore implant and a single crown. The diagnostic records in this case included a CT scan in order to be able to accurately assess the preoperative subantral bone levels at the intended implant sites. This CT scan indicated approximately 6 millimeters of subantral bone at the second premolar site and approximately 4 millimeters of subantral bone at the first molar site. Alveolar ridge widths were well beyond the minimum of 5 to 6 millimeters, while the bone density measurements in Hounsfield units indicated primarily cancellous bone. The flap was designed with a palatal paracrestal incision extending distally from the distal palatal aspect of the first premolar tooth. A buccal intrasulcular incision about this same tooth was used to avoid a vertical releasing incision anteriorly. However, a vertical releasing incision was used at the distal termination of the flap to provide sufficient access to the underlying bone. Having made these incisions, a full-thickness mucoperiosteal flap was raised towards the buccal in order to expose the intended implant sites. A surgical guide was then employed to mark the implant sites, keeping in mind that there must be a horizontal distance of 3 millimeters between the distal of the first premolar tooth and the mesial aspect of the second premolar implant, and a similar distance of 3 millimeters between the 2 implants. Because the Endopore implant is a press-fit design, it's ideal for placement with hand osteotomes in bone of low density. There are 3 osteotome tips of increasing diameter provided in the Endopore surgical instrument kit. The smallest diameter, or number 1 osteotome tip, is connected to an osteotome handle and used to test the bone quality in the first implant site. It's placed into the site, previously marked by the round burr, taking great care to position it with the correct orientation for eventual implant placement. The surgical mallet is then used to tap gently on the end of the osteotome handle. In primarily cancellous bone, the cutting edge of the osteotome tip will advance easily at a rate of approximately 1/2 millimeter or more per tap of the mallet. Since there was approximately 6 millimeters of existing subantral bone at the second premolar site, the number 1 osteotome tip was seated only to a depth of 5 millimeters, using the appropriate mark on the osteotome handle as a guide. The markings on the osteotome tips correspond to depths of 5, 7, 9, and 12 millimeters. The number 2 and number 3 osteotome tips were then used in sequence to widen the osteotomy to the same depth of 5 millimeters. As no graft particles were needed to help with stabilization at the apex of this first implant, the number 3 osteotome tip was then tapped to the full depth of 7 millimeters needed to receive the implant. The plug of autogenous bone, automatically compacted and collected apically by the advancing osteotome tips, was considered sufficient to elevate the Schneiderian membrane at this site. In order to finish the development of the osteotomy, the trial fit gauge corresponding to a 7 millimeter long by 4.1 millimeter diameter Endopore implant was connected to an osteotome handle and fully seated with the use of the surgical mallet. At this point, the handle was disconnected from the trial fit to allow the latter to be used as a direction indicator for the development of the second osteotomy site. The second implant site was then developed, beginning first with the smallest diameter or number 1 osteotome tip. In this site, there was only about 4 millimeters of bone remaining below the sinus floor. Knowing this, the osteotomy was developed to a depth just short of the sinus floor with all 3 osteotome tips, before upfracturing the cortical sinus floor with the largest diameter, or number 3 osteotome tip. A sudden reduction in resistance to the advance of the osteotome tip should be easily detected as this upfracturing occurs. At this point, it's generally wise to add a graft material of mineralized particulate cancellous bone to supplement the autogenous bone plug that has already been collected at the apex of the osteotomy. This is done because a significant sinus floor elevation of approximately 3 millimeters is needed at this site, and the graft material will help to tent up the Schneiderian membrane and to stabilize the implant apex. Having added the graft material, the number 3 osteotome tip, or as in this case, the 7 millimeter by 4.1 millimeter diameter trial fit gauge, is reinserted into the osteotomy and advanced approximately 1 millimeter more in depth with the aid of the surgical mallet. Thereafter, the sequence of adding graft particles and advancing the osteotome tip or trial fit gauge by a further 1 millimeter in depth is repeated until the full depth of 7 millimeters is achieved.